Great. So yeah, hello. Thank you for coming. Happy Friday, as always. Welcome to our community of practice. It's our last community of practice for the year 2024. Ew, but yay. We've had a long year of a lot of fruitful discussion. I love that for us. But yes, there will not be one next month because of the holidays. So yeah, next time we'll see you, it'll be in the new year. So if you received our email reminder, you know that today we're holding an informal panel for law enforcement folks to come and talk about their experience with AOT in their roles. So yeah, the more that we've dived into our focus groups and engaging with y'all in this space, we see that understanding what other parts of the system are doing, it is so invaluable in understanding how they're operating and what they're doing. So we have Dr. Scott Smith here to help facilitate the panel discussion. Scott has worked closely with law enforcement since 2006, including work as a reserve officer and providing behavioral and psychological support to law enforcement. And on our panel today, we have Deputy Richard Traskos from Washtenaw, Detective Bruce Morningstar from Muskegon County, Detective Sergeant Michael Matthews from U of M, and Officer Matthew Meisel from Bay County. So thank you all so much for taking your time out of your day to be here. And of course, like every month, I want to plug our other AOT opportunities that we have. Twice a month, Scott, actually, who's here today, is available for a drop-in Q&A session. Anyone can come to these sessions with any AOT-related questions or case questions. If you have something super specific, something super broad, feel free to come into these drop-in sessions. Because they're like kind of structured like office hours, you can come in anytime in that hour span. It doesn't have to be right at the start. So I also like to say that this is a great resource to share with families and loved ones of AOT consumers if they have any questions or anything like that as well. So next month it's going to be Monday, December 9th from 11 to 12, and then Wednesday, December 18th from 2 to 3. I'll go ahead and drop that in the chat when I get a second here. But if you have any questions that do not get addressed here today, be sure to attend one of those Q&A sessions. Again, these are open to everyone and anyone with an AOT related question. So yeah, now without further ado, we'll go ahead and transition into our panel discussion, and I'll throw it over to Scott now. Take it away, Scott.
Thank you so much, Olivia, and a very happy Friday to everyone. To get the conversation started, I would just love the panelists to go ahead and describe what their role is in the AOT process and how that looks in their agency. And Deputy Traskos, I'll go ahead and kick it to you first.
Well, thanks for making me first. I'm a little spoiled at my agency. I'm part of our co-response unit, so I am partnered with a master's level clinician. 24 every shift I work, I'm with her. So my involvement with the AOT is when essentially once like a pickup order is issued, it becomes my job to kind of get that person. As far as AOTs, I'm not doing any of the court process with it. Our county CMH handles all of that. So we're just affecting the pickup orders. I like to explain to deputies that don't understand what's going on with them that it's kind of like being on probation, but for mental health. So it's easier to get a pickup order for probation to be to get an arrest warrant, but it's easier to get a pickup order than it would be normally by just needing a petition and not having any background on the person. But yeah, like I said, I'm spoiled. So I have my partner. She kind of tells me what to do and I make it happen.
Excellent. Officer Meisel, would love to hear from your perspective.
Well, first off, happy Friday. Thanks for having us be a part of this group. Obviously, it's very important and we feel honored to be a part of it. So thank you. Basically, I'm assigned to the patrol operations, and community mental health just started riding with us about 6 months ago, and it's been instrumental in our community, just building that trust. They've been going with us on all pickup orders, and just basically building a relationship with the individuals that we deal with. So usually about once or twice a week, we'll have the mobile response team through mental health ride with us, We respond to all check the well-beings with that person, get them the resources that are available here in Bay County. Kind of how the process works. Once the petition's issued, we try to find that individual in the community in transport. We transport ourselves to the hospital. If necessary, we have an ambulance that, corresponds with our response, but typically we're able to build that trust with the mobile response team. So it's been extremely beneficial. And like I said, we're extremely happy to have them part of our agency.
Excellent. Detective Morningstar, what would you add? What happens with your organization?
Not a lot to add, I guess. Very similar situation in our community. I have an embedded clinician that works in our agency as well. And I'll tell you that AOT has been one of the things that we have, it's been kind of a blessing and a curse. The blessing is that they exist. The curse is, it seems like throughout our community, there's a lot of misunderstanding about how they work and when somebody's not compliant. And a lot of times when I think there's a lot of misconception for law enforcement when they see an AOT entry in lien that says a mental order. And so there's some confusion about that, I think, across the board throughout the state. As I travel throughout the state and help do some trainings on this type of stuff, I think there's a lot of confusion about how AOT works and how to make it most successful in our community.
And we've heard a lot from that, and there's been some confusion understanding which orders are entered into lien. And I'm grateful that you're out there helping to provide some better clarity to other departments. That's invaluable. And last but not least, Detective Sergeant Matthews, would love to hear from your perspective. And for those of you who might not know, University of Michigan Public Safety, they actually get to cover a lot of different venues. So in addition to policing one of the largest campuses certainly in the state and even in the country, they're responsible for a lot of the security that's under their umbrella shared team there that helps with the hospital side of things as well. So as an organization, I know they get to see a lot of different aspects of this. So without more of a prelude, I guess, I'll hand it over to you, Detective Sergeant, and let you tell us a little bit what it's like for you.
Thank you and good morning. My role is a little bit different in that I'm assigned to the Detective Bureau. So by the time that we have interaction with someone with a AOT, we've seen numerous reports on them, and my job is to kind of coordinate the response between our department and CMH in terms of getting a pickup order or trying to get an ERPO or something like that, or trying to avoid criminalization or something like that. We do have a lot of younger people on campus that we run on that are in a mental health crisis that seems to take up the majority of our time. These are people that aren't usually in the community mental health CMH process or list, although potentially, down the road they could become consumers in that respect. But from my point of view, like I said, it's just making those connections from our patrol officers who run on these calls with community mental health and try to get them further help. So they're not tying up some of the resources that we have. So most of the stuff that we deal with are the university seems to attract a fixation from people that have some mental health stuff going on. So frequent annoying, harassing calls or showing up in places trying to make contact with the president of the university or people on the football team, that sort of thing. And so once the repeated contact is made and it becomes aware, then I'll make outreach and try to get services and support to those people.
Thank you so much for that. Kind of our next question transition into that relationship with CMH, and would love to hear from all of our panelists on, like how that relationship in your experience kind of got going, and how you see your role in working with the CMH. So actually, I'll start with you, Officer Meisel.
Like I said, our department is new to having mental health professionals within our agency. So basically, they attend our roll calls both day and night shift. The individual Jill Schultz coordinates the individuals who ride with us, and it's so nice to know what is happening with the individuals that we either petition, that we go on check the well-beings multiple times a week, and just diving in to better understand what is going in to the mental health. I mean, it's obviously that's the way law enforcement's going. Is back when I started 15 years ago, it was just, oh, we're cops, we're taking this person to the hospital and can't wait to get them out of our car and we're done. But now that we slow down and realize that, hey, these people actually do need our help, and just learning from mental health, the different, I want to say, resources that are out there. It's been an amazing, to see, how beneficial they truly are. So like I said, they come to our roll calls, they ride with us once or twice a week, and we can call them, day or night, and they'll answer and kind of help us with the petition process, what resources we can provide to that individual to get them the help they need.
Excellent. Detective Morningstar, how about for you?
Would say that our collaboration kind of started when we started a CIT program in our community. And I think that there was a lot of resistance, kind of maybe on both sides, about collaboration at first. I think that there were some misperceptions about each other's professions and what we do and how we can work together. And I'll tell you, like the growth has been, it's taken not that long to realize that there is this benefit for collaboration. And I think that now that we have an embedded clinician in our agency, we only have one that does Monday through Friday. I think that now we want one on every shift. I think that our officers at first, again, we're kind of resistant to having that person in the car, having them respond, and boy, are we going to be responsible for that person's safety as well? And there was a lot of stuff that was going on. But I'll tell you that the more that we have worked together, the more that we find the benefit in working together. And even the officers that were initially resistant now are some of the first ones to call and say, hey, our embedded clinician's name is Carrie. And so they're always calling me saying, hey, is Carrie working today? We need her out here. So really good relationship in our agency.
That's outstanding. It's so great to hear. And I saved Deputy Traskos and Detective Sergeant Matthews for the end because you share CMH. And so I'll open it up to both of you to kind of talk about what your relationship is. And, Detective Sergeant Matthews, you had mentioned that many of the calls you go on are not yet individuals who are directly consumers of CMH services, especially because, with the expansion of care that happened in 2013, many individuals are now covered on their parents' insurance until 2016, which traditionally keeps them out of eligibility for CMH. But we know one of the struggles is trying to identify those people who will ultimately be served by the CMH. So I guess I'll look to you first, Deputy Traskos, and let you kind of describe what things are like. You did a great job already, but if you want to elaborate on anything.
I just didn't think I was going to be first. So our relationship with CMH started probably, I think it was 2015, 2016. We had a near critical incident involving a subject who actually is currently on an AOT. After that, the sheriff sent several of us to CIT training, and those same group became verbal de-escalation instructors. After CIT training, we did ride-alongs with CMH crisis team, and they came and did ride-alongs with us, which kind of established a pretty good relationship where we kind of understand a little bit more of what each person's job is. Fast forward to 2022, I believe it was, Deputy Roy, who's my counterpart, he started the first CRU car, co-response car in Washtenaw County, and he works from 7 p.m. to 7 a.m. We work 12-hour shifts, so it's rotational leave days. And he's partnered with Christine, who's a CMH crisis worker. I started still instruct verbal de-escalation and responding to mental health crisis and whatnot for law enforcement. And then I started in July of this year with Emily from the CMH crisis team. And we're always together. We're always partners. And we work 12. So we work 10 a.m. to 10 p.m. We respond to any mental health calls. We respond to anything, pretty much anything people need help with. We're not a criminal response unit. If there is like a hot run, like a shooting or something like that, we will show up and assist. But otherwise, we're not responding to criminal complaints at all. My joke is I'm her bodyguard and her driver, and we go out. I make sure she's safe, and we handle what needs to be done. We kind of bridge the gap between CMH needing to call law enforcement to assist them, and then those law enforcement that might not be familiar with what's going on, showing up and helping, and maybe not rendering the best care. And we can also show up on a scene where deputies are dealing with someone in some kind of crisis or dealing with not even crisis level, just some issues. And we have all the time in the world to deal with the situation. Whereas a road patrol guy, we got board, the board stacked, there's 20 runs to go to. They're going to try and get in and out as quick as they can, where we can dedicate as much time as we need. Yeah, but it's been working good. I mean, Emily and I have over 400 contacts since July with people. I think the units between the two of them, we've got over about 2,000 contacts. And we're able to divert a lot of people. The Bay City officer, I believe it is, was saying earlier, we transport every chance we get. It's great to give people the option, whether they want to go with us or with an ambulance. It gives them some control in the situation. And as long as they're not, extremely violent or combative, they usually go with us. We give them a ride, and it allows us that extra time to talk, establish rapport. We carry food, water, blankets, socks, all sorts of stuff, accoutrements, if you will, in the car. People might need something. We had a gentleman the other day that was kind of refusing to go. He was really sick, really needed to go, but we were able to kind of bribe him with chips. He wanted chips and something to drink. So we got you. Go ahead and hop in, and we got him where he needed to be. So, but we've got a really good relationship with CMH in our county. At least the deputies do. I can't speak for other agencies, but as the sheriff's office, we have a pretty good relationship.
Detective Sergeant Matthews, what would you add?
Just to tag on to it, I don't know if Deputy Traskos monitors Metro East or West, but so our county is divided by like a central dispatch, East and West, and I typically hear Ann Arbor PD calling for community mental health response on Metro West, so I'm not sure if he's aware of that, but they, aside from our agency, other agencies know that that's a valuable resource and are often calling for it when they're dealing with people in crisis. As far as our agency, I would like to think that we've had a long-standing history with community mental health, going back to the early 2000s when we were bringing in community mental health workers to talk to and conduct training for our department. As far as outreach goes, before there was any BHEP or any structurized training. And now, aside from that, our officers, like I had mentioned, run on a lot of young adult people that are in crisis, either because they've been removed from the home and they're here studying and they don't have that structure or stability that they're used to, or it's just a new onset of a mental illness coming out due to the changes in their environment or whatnot. So I like to think that our officers are fairly adequate at dealing with people in crisis just from our younger population that we have to deal with. So, but they'll call as needed, but they'll, make the attempt first to establish rapport and communication, and us transporting is fairly easy because we do have the psychiatric emergency services here on campus, and we're only 5 minutes at the most away from that service anywhere on campus. So
Good. So the next question is really about what you wish other entities knew about your role, specifically with AOT, but I would expand that to also involve like all calls that are related to like a mental health crisis. We know one of the big challenges in kind of coordinating care is that every entity involved in this process has its own rules and regulations that make free communication and sharing of information a bit challenging. And I think it's very easy for us to know our side of the equation and not really have that frame of reference for other people. So I would love you to share like what you wish CMH, emergency departments, et cetera, knew about your role and the way that you have to go about handling things. And I'll start with you, Officer Meisel.
I love, hearing the stories from, Wash and all there about having, basically a partner that is a professional with, community mental health. I'm just not just a road officer, but when I was assigned to the community policing unit, we had time to, really pour in to the people that we're responding to. Whereas right now we just, there's, like I said, once or twice a week, there's somebody riding with us. And when we don't have somebody here, we call the mobile response team. Well, they're only open from 8 a.m. until 4 p.m. So after that, it's night shift. And obviously there's, 30 calls on the board. So they're just, it's just staffing. That's what I really wish that, we had the staffing that was able to, pour into our department, having one per shift, and really help us, write these petitions. Because a lot of times we get to the hospital and, the petition's not certed. The doctor's like, what are you bringing this guy here for again? Well, here are the new observations. Well, that they don't want to be here and this petition's no good. So here you go. Whereas I feel if we had like a CMH worker with us, they could say, hey, this is what we're observing. It's just, hopefully we can get to that. So I'm going to definitely talk to the captain and, talk to Jill from CMH and see what we can do it's beneficial. So I think it just comes down to staffing like anybody.
Absolutely. Deputy Traskos.
I guess the biggest thing for us, I should say, for our CMH, is probably they notice a huge difference between how agencies respond, because we have so many agencies in Washtenaw County. Because we've got deputies that patrol areas where there aren't cities. So like I'm assigned to Ypsi Township, but if there's a call that needs us, we'll go anywhere in the county. But Ypsi Township surrounds Ypsi City. Then it borders Pittsfield Township, which borders Ann Arbor. So there's a lot of jurisdictions all in the same area. They all have policies and procedures they follow. And how they handle situations is different. The training they have is different. The culture of their agency is different. And it's all in one area. So I kind of feel for CMH because they have to deal with everything. It's not just dealing with just us kind of thing. The one thing I would say, I don't know if there's crisis workers in here, is be more assertive with police officers, not to the point where it's a problem, but after talking with a lot of crisis workers, they say, this person should go to the hospital kind of thing. And the cops are like, no, they need to be a little more assertive and understanding like the mental health law and be a little more assertive with, they should really be going to the hospital instead of just taking the cops. No, I don't want to first. That'd be a huge thing for me, just to pass along to everyone. But like I said, we're spoiled just because of how we have it. And they want more cars here, but we have staffing issues as well. They want to have 24/7 coverage countywide, but we don't have enough crisis workers and we don't have enough cops. So, but back to what he was saying about the petitions as well. Like I didn't know until I was riding with my partner, half the petitions I wrote before, and I thought I was smart, evidently just get shredded at the hospital and rewrote. So it's awesome having a partner that knows all the big words. I'm learning some of them, but it's super important to have that partnership.
Excellent. Detective Sergeant Matthews.
Yeah, regarding those big words, we issued our officers like kind of a cheat sheet that's double-sided that has a bunch of big mental health DSM words in it that they can relate under their petition. Because as I said, we do get a lot of people. And then in particular with the petition and certification process, we are the agency that responds if another agency brings in somebody on a petition and maybe Michigan Medicine doesn't keep a careful eye on them and they decide to elope, and then we get called for a subject walking down the street that's suicidal that needs to be brought back, and we have to deal with the petition process or the certification or a clinical certificate process to see if those are have been signed and are valid, and if not, then we have to go out on our own and make our own observations. So for our agency, you know, we do have CMH that we can rely on, but we also we always kind of err on the side of caution. So if we get contacted regarding someone who's suicidal, our stance is usually unless there's contrary evidence and that person is, you know, 5x5, super sound and everything, we are on the side of caution by taking them to PES, whether that means you know, kind of convincing them, hey, if you check yourself in, you can check yourself out type of thing, or taking them into protective custody and transporting them. Again, we'd rather, I guess, pass the buck to a more highly trained clinician than make that type of judgment on the street and have something go bad.
Thank you. And last but not least, Detective Morningstar.
Would say that our response, I guess, in law enforcement hasn't really changed. A lot of times we're dispatched to calls that don't necessarily need a law enforcement response. They're looking for help from anybody. So that's why they call 911. And so often law enforcement is that first contact made in the community with somebody that might be in need of some mental health services, but they're not looking for the police. They're not looking for fire. They're not looking for ambulance. But 911 has basically those three options available. So generally speaking, the police get dispatched these calls. And I think in our community, it's helped a lot. I like to say that we thought of this, but we just stole it from some other community. We do a lot of referrals on the off shifts. So when our mental health clinician is not riding along with us in the evenings and on the weekends, we'll do a referral process to community mental health to do a follow-up contact with that individual. And that has been a huge improvement in the process and trying to cut down those repeated calls that law enforcement go to over and over again, and kind of end up having a little bit of compassion fatigue as a result of going back over and over again. And so I think that process has helped us a lot in making those connections at the early stages of mental illness and trying to get people the care that they actually need, kind of connecting them to the right door at the right time. I think for so long we've been kind of like putting Band-Aids on stuff as law enforcement will respond. We decide that the person either needs to go or doesn't need to go to the hospital. There's no criminal act here. And so we kind of move on and just kind of put the Band-Aid on, kind of hope that we don't get called back there by the end of our shift. And maybe the next shift has to deal with it. And they put a Band-Aid on it. And it's a continual Band-Aid process when really what's needed is somebody with that surgical expertise, you know, that somebody that's well-trained in this area to provide the assistance that they actually need. I think that also there was discussion about getting the assistance in getting somebody petitioned at the hospital and actually getting that to work the way it's supposed to. I would say that we also have pretty good luck in having our embedded clinician help us determine that it doesn't make sense to take this person to the hospital. So when they're on scene, they can help to evaluate that person on scene, similar to how they would in the hospital, and say, you know, hey, this is this person's baseline. There's no need to take that person to the hospital. Let's not waste anybody's time, get anybody hurt or anything that like that doesn't need to happen. So we've had a lot of success there as well.
Great. And this next kind of question kind of dovetails a little bit off of this, but it's more about what you really wish you could have, specifically when you're executing an order for transport and examination. And so what I want to know is, what's the information that you really wish you could have? So I'll share a more personal story. One of the first shifts I worked as a reserve officer, we went to do a pickup order. I looked at the cert and the attached pickup order and noticed that the individual had a traumatic brain injury, and it was specific to the prefrontal lobe, which I knew meant this is somebody who's going to have great difficulty with impulse control, emotional regulation, etc. And so I immediately knew that this was actually a more dangerous situation than perhaps, a regular officer would get to know. And again, being both a clinician and now serving as a reserve officer, we were able to make that transition go smoothly. But this past summer, I had to do a critical incident debriefing for a department where very similar situation. It was a traumatic brain injury, and the individual got very combative. An officer was very seriously injured. And so I think that, we're asking a lot from law enforcement to help out in the mental health crisis. What do you wish you could have going into things, specifically with orders for transport and examination? And I'll actually start with you, Detective Sergeant Matthews.
Yeah, I think it would be helpful if we have that order for transport or pickup where we're communicating with community mental health. Whenever law enforcement, whenever we go serve an arrest warrant for a felony or do a search warrant at someone's home, we kind of have a threat matrix that we go over, and that looks at tries to look at the big picture. The suspect, for instance, the types of felonies they have they been violent felonies? Have they resisted arrest? Do they own weapons or have access to weapons? And then the house has PD running on the house before. Is there other people living in the house? That sort of thing. So it paints a picture as to how we're going to go in, and with a pickup order, it could be, kind of like you said, the subject has a traumatic brain injury or is easily startled or, has fought, at least so we have some awareness, and that may be when we respond, maybe we have additional backup, and maybe they're not deployed at the time that we're making contact with that person for the pickup order, but maybe they're right around the corner in case we need to help manage that person and do it in a way where we're not harming them, but we have more bodies to kind of overwhelm or overpower them safely so we can get them transported. So maybe something in terms of that, of a debrief or a pre-brief before we go and make contact with that pickup order.
Helpful. How about from you, Officer Meisel? What would you add?
Exactly, what he said is it's just having more knowledge before we are executing these, pickup orders. It's just I tell our new officers, it's the same as, doing a felony warrant. These people, are unpredictable. And when we get a petition, it's just, 2 lines on it tell us their whole history. So I always try to look up reports, see if we've dealt with them before, see if there's weapons in the home, see if there's somebody else in the home that we can build rapport with before we just, knock on the door and, hey, city police, you're going to the hospital. Trying, like I said, build that rapport. And when I do them, I usually try to establish, like I said, some rapport with the person I'm picking up. I'll talk to them for a half an hour before we go to the hospital, just so we can build some trust between each other. Hey, I'm taking you down, talk to the professionals. That doesn't mean you're going to spend 30 days in the hospital, but you have a pickup order. So just, like I said, getting more information before we're doing these pickup orders. I'd love to see a CMET or a community mental health worker go with us when we're doing these executions of these pickup orders, which I think that's kind of our long-term goal. So that's just kind of where I see our agency going. So more information.
Absolutely, absolutely. Detective Morningstar.
I think you bring up a good point about having that information up front for officers to know about. I think back to a situation where I did ride along with our community mental health, and we went to an AFC home. There was a gentleman that, before we walked in, the social worker I was riding with actually said, "Hey, just so you know, when we go in here, there's a guy in here that has this mannerism. Well, he will grab onto people's hair and he won't let go." And, fortunately for me, I don't have to worry about that. But I think she was trying to let me know that because inside the home, that actually did happen. I think she was just saying, hey, this is normal. This is his thing. And so the staff knows how to deal with it. All the residents inside here know that happens. So don't overreact when you see it. And it did happen while we're there. But I was thinking as we drove away from there, what if that person walked away from that AFC home and there was a BOL put out for that individual as a missing person? That'd be pretty important for law enforcement to know. So those little tiny intricacies about what will make a successful interaction versus a tragic interaction. Because obviously, if law enforcement didn't know that, they approached that individual and he reached out and grabs onto their hair, it's going to be a bad day for everybody. And so I think it can be avoided if we have some of those tidbits of information to before we make contact. I would also, I'm sorry. I would also say that there's been a little bit of reluctance in our community sometimes when we've asked for social workers to go along with us to do these orders. And I think that there's a little bit of resistance because they might know that this might involve some hands-on necessity and they don't want to be there. They kind of want to, I don't want to say want the police to be the bad guys, but I think that they don't want to be associated with that interaction that individual is having if it requires hands-on. And I just want to kind of bust through that barrier somehow and help them realize that sometimes if they are there, it might not result in hands-on. And so if we could have their assistance on the scene, that would be beneficial in most cases, I think.
Especially a familiar presence can be a great de-escalation tool as well. And I actually think back in 2021, Detective Sergeant Matthews, Harold Love and I were with you over the course of a month doing a bunch of repeated trainings for you. And I remember one of those sessions at U of M showing the video about somebody experiencing auditory hallucinations walking through a convenience store and the way that, how preoccupied this individual was by those voices. And I remember one of your officers saying, they would never hear a word I said. And just this kind of sheer terror of, oh my gosh, I would completely misread that situation. And similar to the example you provided, Detective Morningstar, the forced grasping that we see with many individuals who are experiencing catatonia, that's one of those nightmare scenarios for me as a clinician familiar with law enforcement that I don't know how you would interpret that behavior through any other lens. So definitely an important reminder for just the need for ongoing, training and collaboration. And since I've picked on Deputy Trascos and made him go first so many times, I let him graciously go last this time. So what would you add that you would love to know before you do these orders?
I appreciate it. So like I said, we're spoiled in Washtenaw County 99.9% of the time when we're doing a pickup order or a petition on a person, CMH is there with us. A lot of times if they get a pickup order for a person, we meet with them down the street before we even make contact at the address. We can kind of get a backstory on what's going on. That being said, I do have a lot more information now being partnered with a clinician than before. Like we had one gentleman that I didn't know last time we did a pickup order on him. He assaulted a police officer because no one ever put it in their report. They just put, TOT hospital in their report and that was it. So I was able to have that information from CMH because I wouldn't have gotten that normally. One thing I would love to see that we've talked about, we're trying to figure out is for dispatch, we have Delta houses where it's a warning on a house where a person is previously barricaded or assaulted officers or something of that nature. So automatically responding officers know when they're going to that house that there's a history there and it references reports and what took place. Is they've been trying to figure out, they haven't really figured it out yet, is doing a way to do that for mental health calls at residences and also by name, because a lot of the individuals we deal with may not necessarily live in the same place. They move around or they're homeless at the time or anything like that, but being able to give officers that information beforehand would be awesome. But yeah, like I think it was Detective Morningstar was saying, having a clinician there, especially if they have a rapport with the person, is way more important than having a cop there. Like we're the force at that point, right? If you're in a mental health crisis or have a diagnosis and you've had a lot of interaction with law enforcement, a lot of it's probably going to not be the best interaction with law enforcement. We're not perfect, and a lot of times behaviors can be misrepresented as violence or something of that nature. And they may not have the best rapport with a police officer. And sometimes cops just have punchable faces. So having a social worker there helping can help a lot. It can take something that could potentially be violent and bring it down a little bit.
This is why I shouldn't let you go laugh. Okay, punchable faces. That's I understand. I identify with that. Great. So with our remaining time, we want to transition more into the Q&A session. So go ahead, and if I don't see anything put specifically into the chat right now, so if you want to raise a hand or just unmute yourself and talk louder than somebody else, we'll open it up.
Is any of the work that's done by the responding social workers billable, especially if the client is open to that CMH?
My partner says yes.
I can concur that that's true.
Yeah, and I know that there's been significant movement to not only expand the ability to bill for crisis calls, a crisis service in different settings, but as well, we're working on trying to change the legislation of who can be part of billing, especially trying to see if we can get peers able to bill more directly to really expand that behavioral health response. So great question, and stay tuned. I know that that's something CMHA has been taking up this year in particular. Well, while other people are forming a question, one question that has come up in a variety of different settings that I would love this panel to respond to is really more about not the order for transport, but rather, let's say we have a client that hasn't been making appointments. We're concerned for their safety, and we want to do a welfare check. What is the information that you would need to know, and under what circumstances during a welfare check can you actually be more, let's say, assertive about verifying the individual's well-being? So Officer Meisel, if you'd like to chime in.
Yeah. I think it's like I said, I'm new to the whole community mental health, but I've really grasped just a passion for it. Like I said, I was assigned to our community policing unit for 4 years, and just when Jill started this program with us, we were very, very hesitant. And it's just, it's become a family. And it's, she comes to roll calls. I call her my mom. But it's been great because you got to build a connection with your community. And I was born and raised in Bay City, so I'm a little, I'm biased when it comes to our city, but it's getting the resources that are available, because there's not a lot of people that know what we have to offer. It's slowing down and educating people about the service that we provide. When we first started the mobile response team, I can remember, last year it was, hey, here's a business card, call them and they'll come out, within the next couple hours. Now, we call them, they're there within 15 minutes. And it's awesome to share, like I said, the resources that are available here in the city, in the county. So.
How about from you, Detective Morningstar?
Sorry, I got sidetracked in my thoughts there. Can you repeat your question?
Absolutely. Absolutely. So in terms of welfare checks, when especially mental health worker is concerned about one of their clients. What information do you like to have? What is kind of the scope of what you're able to do to verify that somebody is actually safe when they're in their home?
Yeah, thank you for that. I would say that what I would want to have is that collaborative response. So the mental health professional going along with me to the residents to do that welfare check. I think that, again, having information up front about how the person might react to the police. You know, I have the benefit in my agency of deciding whether or not I'm going to be in uniform for the day or in plain clothes. And so I might vary how I respond to a specific situation based on that. And so I would want that collaboration. I would say that when we get there, you know, obviously in most situations, we're not forcing a door open to check on somebody's well-being unless we have some reason that there's some exigent circumstances that we have to. But I would say that part of the problem, I think, sometimes is if we go back to the AOT thoughts here, that I think that there are challenges sometimes with who's making sure that that AOT process is fulfilled. And if that person kind of falls off the face of the planet in one county, how does another county know about the fact? So if somebody in Muskegon County, where I work, ends up over in Washtenaw County, and they were on an AOT over here, but they stopped going to meetings, they stopped getting medications refilled and things like that, and they make their way over to Washtenaw County, I think that sometimes that's where they fall through the cracks, because I think that they kind of get, for lack of a better term, closed out in the local system, and then there's no connection point later on. They just kind of, they're out there in the wind, so to speak, without any treatment, and I think that can be dangerous.
Yeah, and that, you know, is a concern that's come up from, you know, many CMHs, is that you know, somebody very often just needs to travel a short distance to cross the county line, and now everything's more opaque, or in some cases cross the state line. We even had a case recently where the person crossed the border and went into Canada. So certainly that creates unique challenges. The good news here is that there has been some movement on the legislative side to try to create more of a centralized probate record, so that it's easier for all involved to be able to get information to check something. Because as we mentioned at the top of the hour, lien is only going to include AOTs if the individual is on a combined order, not if it's an AOT only order. So even that is not as accurate, and lien is very restrictive in terms of who can access it. So it's not a great fix for this challenge. So I'm really glad you brought that up. Dr. Sergeant Matthews, what would you add in terms of doing welfare checks?
I think it depends on when that welfare check comes in and who's doing the background information. If it comes into me during the day and we've got the time, then we'll check them through LEAN, Law Enforcement Information Network. We'll check them through our in-house record systems, or through something like CLEMIS, which is what other agencies use, which is another report writing system. And if we got the time as well, we'll check on 22nd Circuit Court to see if there are any orders or prior orders, which a lot of times there are, that will give us a little bit heads up. But that being said, it could be a midnight shift dispatcher and they don't have the knowledge or whatever, and they'll just send an officer out. So it really varies. The more information, obviously, that's given to us to check on that person, the better the outcome. You know, we've run the gambit from a licensed therapist contacting us. I haven't heard from this person in a couple of days. Can you go check on them? And that person was deceased. To kind of a co-occurring thing where CMH, or I should say the hospital, calls for a welfare check on one of their employees. We make contact with the family. We also coordinate with CMH, and we see that they're going through crisis, and this is a pattern of behavior where once their medications start to wean off, they're given monthly injections. So once those injections start to wean off, their behavior spikes and they become a problem. So it's with sharing information, coordinating with CMH, where we get them into a sooner than later appointment where they can have another injection, and a psychiatrist can look at what medications are given or what dose to adjust that accordingly. So, that person isn't at the end of every month becoming problematic because the medication's wearing off. So it's just information sharing. I know there's HIPAA and stuff like that. The way I present or go about it is I try to share as much information from my side as possible, just in the interest of cooperating, knowing that I'm probably not going to get the same back, but information is power. So, and I feel compelled to share it when I can.
Great. And just as a reminder to all of the clinical professionals on the call, HIPAA has several exclusions for law enforcement and sharing of information, specifically when a person's in crisis or is in danger. And there's actually a very helpful brochure about HIPAA and law enforcement. And I'll have Olivia remind me to get that or to help distribute that to everybody. That can be invaluable, can be a lifesaver truly. So I think that's a great reminder. And I want to segue real quickly. We had a question from Megan Herbert that basically she states they've been running into situations where different law enforcement organizations have different policies on whether they will transport somebody if they don't have a raised seal copy of the transport order or an signed cert. So actually, I would love to hear from you, Detective Morningstar, since you're involved in doing different trainings. Has there been any move to try to standardize what is required, what is considered acceptable for law enforcement to take action?
I've heard of this issue. We don't have that here in our community locally, but I've heard about that as we go throughout the state. And I would say that probably some of the challenges that come with that are, I think the reason they want the signed seal is very similar to when an arrest warrant goes into lien. There's a way to know that arrest warrant has been served, and so the signed or the raised seal one is kind of like, this is the one. So if you have one that doesn't have a raised seal, you should verify that it's actually a valid order still. And so that's wonderful. But I think, again, once we cross some jurisdictional lines, a lot of jurisdictions will put out like a BOL for somebody that has an AOT pickup or a petition to pick up. And we've had, unfortunately, in our community where somebody's been picked up twice on the same one because there was some misunderstanding about whether or not they had already been picked up or not. And sometimes we've had it also where somebody has gone in and they've voluntarily gone into the hospital to have their evaluation done so they don't have to have contact with the police. And so, but the order's still out there with the raised seal. And so there's a lot of problematic stuff that goes on for law enforcement. And I think that I don't want to say it's just from a civil liability perspective, but there's a lot that goes into that there's some decision making that takes place. Like if we pick this person up a second time on the same transport order, that can be problematic. And I just want to, like, for a minute, take that liability perspective out of it and just think about like the consumer that we're taking in to protect custody. If they're taken in twice, the traumatic situation that goes along with that as well, and so while it might seem like it's problematic, it's probably for all the right reasons that they're refusing to take that person in without a raised seal one.
Sorry about that. My microphone would not unmute. Megan actually further clarified that even when they have the raised seal, sometimes they get pushed back. And specifically, depending on the size and the sex of an individual, which seems to me to indicate that, law enforcement, especially because of the scrutiny they get anytime they might have to go hands-on or use any level of force, might be a bit more intrepid about executing some of these orders. What would be maybe some life pro tips you would offer to help maybe build a relationship with that department to see this as something that can benefit them, not just expose them to liability? I'll actually start with you, Officer Meisel.
I'm not familiar with it, to be bluntly honest. Our pickup orders get faxed over to us. So the true order we take to the hospital with us. And it just goes back to building rapport with the individual. It does, and I told you before, the amount of new people, like every agency has, it's just slowing down. Because I can count probably on one hand how many times I've had to fill out a response to resistance, use of force situation with the individual that I'm taking into protective custody. It's just slowing down, building that rapport, even if it takes 20 minutes, 30 minutes. Because I don't want to be liable for taking somebody in that doesn't need to be taken to the ground or whatever it may be. So it's just, like I said, just building rapport with people and just slowing down, kind of understanding what's going on.
That's helpful. And something you had mentioned earlier that, you remember the hesitance, the reluctance, the skepticism of, that early attempt at partnership. And it sounds like it didn't take all that long for that relationship to really grow and turn into something special. So I think that's a great reminder that even when it looks like this relationship isn't going to go anywhere, that often that can change relatively quickly. Well, everyone, we have reached our time. It's noon. From all of us at the CBHJ, we greatly appreciate our panelists and their willingness to come here and share with us. Grateful to all of our attendees. Thank you so much for all of your questions and for all of your communication with each other in the chat. Have a terrific rest of your Friday and a great weekend.
Thank you so much.